Thank you for joining the Human Podcast. Today, I have the absolute pleasure of being joined by two world-leading experts, both my dear friends. We have Dr. Asim, a world-leading preventative cardiologist. He has a global reach and a global voice, and it's a voice that needs to be heard. And we're joined by my personal mentor in functional medicine, who I met 10 years ago as one of the faculty of the Institute of Functional Medicine. I saw him on stage and I was like, wow, I was blown away. This gentleman is a true expert. And what do experts do? They make complex things easy to understand. And he's personally mentored me to drive functional medicine into the UK here at Human. I think we have a fantastic conversation ahead. It's an extremely important topic, cardiometabolic health. And as I get asked to speak more and more about longevity, I come back to the biggest killer, which is heart disease. And often in the longevity world, it's not really brushed aside, but it's not addressed. If you don't mind, give the audience a short introduction.
My name is Asim Malhotra. I'm a consultant cardiologist. I've been a qualified doctor now for 23 years, coming up to 23 years. And I originally trained in interventional cardiology, which in layperson's terms is keyhole heart surgery. And in the last almost 10 years or so, I actually stopped doing that and I shifted more towards prevention. I have special interest in population health as well as helping individual patients, and I am looking into research and trying to push the boundaries on reversal of heart disease.
Dr. Mark.
Well, it's so great to be with you again. We spoke in Galway, Ireland together, and it was one of the most impressive conferences and conference partners that I've ever had, so I was really excited that's the two of us. Dr. Mark Mendelacino from the Medical Clinic, Jackson Hole, Wyoming in the States. I've been passionate about heart disease since I worked with Dean Ornish when I was in high school. And I saw at age 18 that you could reverse the need for a bypass surgery. And I think that's what we share in common, all three of us, is optimizing the health for the individual. So I'm excited to be here, and I think that we have a very important topic to talk about.
Yeah, absolutely. Let's get stuck into it. Where I wanted to start was to articulate and understand for all our audience how big the problem is of heart disease and where it's going. Are we getting better at it? We'll talk particularly in the UK to start with, Asim. What's your feeling of how well we're managing heart disease and managing risk of heart disease?
Yeah, so we made some great inroads in reducing heart disease and more specifically death rates from heart disease in the last few decades. And the most important factor that reduced those death rates was reduction in smoking. That happened because of awareness, but actually more important than the awareness in addition to it was interventions to make the cigarette consumption less available, less affordable, banning advertising of cigarettes, etc. So it became a cultural approach as well across the board. And in fact, the United States were ahead of England in terms of that smoking reduction policies. And the interesting thing about that, which we'll come on to later on diet, is that when they introduced policies to reduce smoking, very, very quickly there was reductions in heart attacks and out-of-hospital cardiac arrest. So Helena, Montana, 2002, when they banned smoking in public places, there was a 40% decline in hospital admissions for heart attacks. 40% absolute decline. Wow. When the law was rescinded because of the tobacco lobby, the admissions went back up to what they were previously. But just to answer your question more specifically, Mohammed, so we've had this massive reduction in heart disease, death rates in heart disease, probably up until the early 2000s, 2010. It then plateaued, and unfortunately in the last few years it's now started to increase again. So we've got a big problem. So it is a major issue. It's still one of the leading killers in the Western world, and we have seen through we won't go into that in a lot of detail, but certainly in the last 2 or 3 years there's now been an increase as well. But multifactorial, of course. For sure. And
in terms of the traditional approach, we're trained in the UK health system where it's a very much nice guideline-led approach where we're treating the average of a curve in terms of our population. So in general practice, we're told if you're above 40 years old and you have a Q risk slightly elevated and your LDL is slightly high, you should be on a statin as a primary prevention. Could you shed some more light on how effective the current guidelines that UK doctors are practicing are?
Yeah, so I think going back to the basics, the 4 traditional risk factors for heart disease, which we're taught in medical school and still are largely true, but with big nuance here, are type 2 diabetes, high blood pressure, high cholesterol, although that should probably be better defined as dyslipidemia, so a cholesterol profile that puts you at increased risk of heart disease, and of course smoking. And the approach has been in medicine primarily to manage those risk factors without addressing the root cause. And that of course brings us back to metabolic health. And metabolic health in simple terms, I'm sure Mark maybe has a better definition than I do, is essentially it's an imbalance that's created in the body linked to often excess body fat. When one looks at heart disease specifically, most of it is actually being driven by poor metabolic health or insulin resistance. Body becomes resistant to hormone insulin over time. So what are those 5 markers? And this is where some interesting data comes. So the 5 markers that we look at are blood pressure. So you want your blood pressure to be less than 120/80, depends which guidelines you look at, but essentially 120/80. You want to have a healthy triglyceride level. In UK we use millimoles, so we want to be less than 1.7 millimoles. I can't quite remember what the...
It's 150 in the US.
150 milligrams per deciliter in the US, that's correct. HDL should be more than 1 millimole, which I think is more than 40 or 50 milligrams.
40.
Yeah. And then waist circumference, which can vary depending on whether you're Caucasian or South Asian. And it should be less than 102 centimeters at the belly button, roughly for a Caucasian man, and less than 90 for a woman. And if you are of South Asian descent, it's a bit less. People from South Asian backgrounds, India for example, tend to develop the diseases of poor metabolic health at lower levels of body fat. Lots of evolutionary explanations behind that. So how many people have optimal metabolic health? And I remember looking at this data in 2020 when, of course, COVID hit, and I was quite vocal trying to show that we should make the link between excess body fat and COVID. I know this talk isn't about COVID, but definitely that is something that has brought it to light because abnormal metabolic health is a massive risk factor for COVID death. In fact, one of the most interesting studies done in the US revealed that when you compare certain risk factors versus people who have perfect metabolic health, the single biggest risk factor for death from COVID was hypertension, which gave people a 37-fold increased risk of death compared to someone who had completely normal metabolic health. In 2020, when you looked at what was the state of the American population, and I'm sure in the UK not dissimilar, only 1 in 8 adults had optimal metabolic health, had all those markers within the normal range. And it wasn't just an issue of aging, only 1 in 4 people under the age of 40 had optimal metabolic health. So it's a massive, massive problem. And the reason we're talking about this is that if you have optimal metabolic health, your chances of developing heart disease are extremely low, extremely low.
And we talk about kind of metabolic health. Mark, what's your kind of thoughts on the relationship between metabolic health, the progression of vessel disease, because ultimately that's what we're talking about, inflammation within the blood vessels and then eventually leading to plaques and then clots?
Well, I think Asim really laid out the groundwork of what we're talking about, is that there are those individual risk factors. And we're really good at population medicine, where we can look at groups and identify information to help us make decisions on populations. The problem is we treat individuals. And so it's all of those risk factors, looking at it in each individual to say, what is your risk? And we're seeing them change. America is getting more inflamed, more stressed out. They're getting fatter, their blood sugar is increasing, their triglycerides are going up. So we're getting an unhealthier population in all of the risk factors. You mentioned the rates of death. Most of my patients are surprised when I ask them, what's your number 1 risk factor? Whether you're a man or woman, they all think it's cancer, but it's heart disease, way up there. What's number 2 in America? As you mentioned, smoking. It's actually lung cancer, smoking and non-smoking. And so that's the highest risk by far for most of us in both countries, and we're so focused on not being able to change those numbers or change our ability to affect our health. And I feel that when you're identifying an individual and you're working on a plan that helps that individual shift, you're really working on the population too.
Yeah.
So you and I are working one at a time to affect a greater change. You're working in the policy, which I really appreciate to see bigger changes that happen. And in America, we've gone the wrong way. Our kids are getting fatter, they're getting more diabetes, the food's not changing, and there's going to be a point where the winds completely push it the other way.
Yeah, and absolutely. And I think the other interesting thing that you alluded to as well, the question that people must be asking is, hold on, if we know metabolic health is a major issue, and we haven't got into that yet, and we know through our own experience with patients that you can reverse metabolic syndrome, which is the worst aspect of metabolic health, very quickly, purely even with dietary changes, but with other lifestyle changes as well. Why is that not common knowledge? And one of the reasons for that is that certainly in heart disease, the primary focus for many decades, and it's still there, has been to lower cholesterol. You know, there was an editor of, if I remember correctly, the American Journal of Cardiology in 2012. His name was William Roberts, and he wrote an article, said it was called "It's the Cholesterol Stupid." Mm-hmm. And in the article, he said, as long as you can be an obese, diabetic, sedentary smoker, but as long as your cholesterol is low enough, you will never develop heart disease, which is just not true. But that feeds into a narrative which supports a drug approach primarily, because dietary changes, you can't lower cholesterol, certainly LDL cholesterol, that much. It promotes a drug-centric approach to managing heart disease. And of course, now we've got, millions of people on statins in the US and the UK. In fact, it's estimated that 1 billion people in the world are prescribed a statin. So this is a flawed approach. Yeah, it's a very flawed approach. Not to say statins don't have a benefit, they do, but they're very marginal when patients are told, they're quite shocked about how marginal the benefits are. But also lowering cholesterol per se, and of course this may be controversial, but this is my independent analysis, peer-reviewed research. I don't have any links to drug industry. We found that looking at drug trials, sponsored by the drug industry, even those trials, there was no consistent relationship with lowering LDL cholesterol and preventing heart attacks in people at high risk of heart disease or even people at low risk. In other words, this model is fatally flawed, but also simultaneously distracts from the kind of things that Mark and I and you do, Mohammed, is that these lifestyle approaches actually have a much bigger impact without the need for pills, without the side effect issue. It's something that big pharma do not, from a financial point of view, do not want to get out, because that's going to affect their profits.
That's such a great point, because what happens is people feel like they can take a medication, then they don't need to do the lifestyle. Well, if I'm on my medicine, it's going to lower the number, then I can have that extra dessert, I can have that fatty food, I don't really need to exercise. So it almost is a dysbehavioral motivator than a behavioral motivator. And I think we all three flip it, is that if we make those lifestyle changes, you won't need to be on a medication.
Sure.
And it's really in the narrative about what's important to people and trying to find for that person in front of us. And that's why medicine's so difficult, because in America you have 7 minutes with a person, and even I think shorter here. How do you understand their needs, their goals, their behavior modification tools? It's very difficult to do all that. You can barely get the prescription written in the 7 minutes that you have with them. So I see why it happens. It's just the wrong model. We call them cholesterol myths. And what's the biggest cholesterol myth? Half the people with heart attacks have normal cholesterol. Half the people with high cholesterol never have a heart attack. It's not just about cholesterol. The other myth is that the cholesterol test tells you whether you're at risk or not. And the traditional cholesterol tests really don't individualize it enough to tell you who's at risk.
Yeah.
And so we just give everybody a medicine, hoping that we're finding the canary in the coal mine. And that type of population pharmacology just doesn't work.
Yeah.
And leads to bad outcomes.
Yeah, you were talking about the Framingham Study at the conference, at the IPM conference, and saying that from 1975, we haven't really changed the way we practice cardiometabolic prevention, let's just say. Tell us a little bit about that.
Well, Asim and I first met when we were speaking together in Galway, Ireland, and he had the actual numbers that I had not seen anybody put together. But the Framingham Study in America took a small town and measured the cholesterol, and based on those numbers determined what was the number to be worried about for people. And it was a cholesterol in America of 200, a LDL of 130, and a triglyceride of 150. And if your numbers weren't above that, you were safe. Well, the traditional cholesterol test just doesn't tell you. And I feel that we're, again, doing population medicine where It's not 1975 and it's not Framingham, Massachusetts. And we're treating everybody like they're the same. And that's part of why the medicines don't work on the entire population. But these cholesterol myths are interesting when you drill down to it. The data doesn't support it. And that's, again, one of the things I appreciate about you. You're a science doctor. And you look at the hard science and make conclusions and choose it for the individual.
Let's dive a bit deeper into cholesterol, because obviously everyone listening is like, wait a minute, like we need to understand, we need to understand cholesterol better. When you talk about treating each person individually, what are you looking for within the cholesterol, and what is the evidence behind that?
Well, cholesterol is not bad. I tell my patients, we're all fatheads because our cholesterol, our brain is made of fat. It's made of cholesterol. We need cholesterol for our hormones, for our vitamin D, for our detoxification pathways. We need cholesterol. There's certain particles of cholesterol that are more dangerous than others. And what we do in our clinic is we're lucky to have the access to 27 different biological markers of your risk. A lot of times it's not the cholesterol, stupid, it's the inflammation. And so we talk about the fire in the heart, the fire in the brain. And the same thing that causes dementia risk is the same thing that causes your heart risk. And that's one way to really think about these risk factors.
And even cancer.
Even cancer.
Yeah.
You mentioned the extra body fat.
Yeah.
It's a heart risk, it's a dementia risk, it's a cancer risk, it's a diabetes risk. So there is a pill for it. Apparently now we have a new medication for it. But it's just trying to bring and activate these changes.
Ozempic, talking about.
Yeah.
Okay. Yeah.
Yeah. We should touch upon that at some point. I'll come back to that. I want to circle back on Ozempic.
Yeah.
The different markers, you talk about the particle sizes within I assume the LDL particles, you can even check different particle sizes within the HDL. You've been testing cholesterols and the breakdown of the sizes of the cholesterol for more than 10 years. That's for as long as I've known you, you've been doing that. Do you want to explain a little bit about the different particle sizes?
Well, I think we got to make it easy because it can get very complicated very fast. Cholesterol is not one thing. We talk about the good cholesterol that is the H or high density lipoprotein, and then the bad LDL. Well, in the LDL, there's 4 subtypes. There's a particular small, sticky, inflammatory one called lipoprotein A. And we never talked about it in medicine until now we have a drug approved for it this year in the US. It's the hottest thing in the literature is this small particle we never worried about. It's actually the biggest risk for women. So it's beyond cholesterol, the good HDL, the bad LDL. There's subtypes of that bad LDL that put you at a higher risk. There's also fractions of it called the apolipoproteins, A and B, and the ratio seems to be predictive. We're fortunate that we have 4 other markers. We have a measure of nitric oxide, SDMA and ADMA, that says how well do your vessels dilate under stress, under exercise, under a fatty meal. Myeloperoxidase, which was just suggested in studies as possibly relating to a dementia marker, early cognitive impairment marker, as well as a heart marker. Plaque2, oxidized LDL. So there's a number of different tests. My favorite test is insulin. If you have a high or elevated fasting insulin, that's my marker of fire in the body. And fire in the heart, fire in the brain, to me is the same thing. So it's not just adjusting the cholesterol, it's looking at all the opportunities. And as you said in the very beginning, Asim, all of the things that you can do lower them by not eating a fatty diet. And I think it's really a sugar diet that's more dangerous than a fat diet, because there are good fats and bad fats.
Yeah.
There is no good sugar.
Yeah.
And it's putting that fire out and thinking about it. And these kind of metaphors help people to understand what we're talking about, is looking at things like the fire in the heart.
Yeah, just on the insulin, it's very interesting you raise that point because I was involved in some research looking at people with FH, so familial hyperlipidemia. People that don't know what that is, it's a genetic condition where people have very high levels of LDL cholesterol and affects about 1 in 250 people. And those people do have in general, they have an elevated risk, but not all of them. So 50% of men will develop heart disease prematurely, they have FH, and 30% of women, which means that 50% of men won't and 70% of women won't. So the question is, can you differentiate between the two so that you're not treating everybody with a statin and cholesterol-lowering drug, because some of those people may not need it. And what we found was there was no difference in the people that developed heart disease with FH versus the ones that didn't in the LDL numbers. So what else is it? And when you look at the most important markers for reduced risk in all comers with people with FH, it's low insulin and low waist circumference. That's it. And their relative risk of heart disease is only very slightly higher than someone without FH.
Why is insulin so bad?
In basic terms, it's directly toxic to the endothelial cells, the inner lining of the coronary arteries. And that's why, interestingly as well, and this is something I when I was doing my research writing, I think it was my third book, Stand Free Life, well-controlled type 1 diabetics will, even really well-controlled, will still have a life expectancy 10 years less than average. And the reason for that probably is because of the insulin. Can they do something about it? Yeah, they can lower their carbs. They can lower their carbohydrate intake and therefore lower the insulin requirement.
You're exactly right, Asim. And to me, insulin is the most inflammatory molecule your body makes. And if you're having these spikes, and a lot of times we don't catch it because there's two types of body fat. There's the regular body fat nobody likes. Then there's the internal visceral, I call it the hot fat, the visceral internal fatty liver inflammatory fat that has a different metabolic pattern than traditional fat. So again, insulin to me is just the biggest marker of inflammation. And what we'll do sometimes is check a challenge with the insulin, have them come in fasting. The hospitals will use a sugar water that they do. We give them a special brand high carb muffin to see, but it's an insulin challenge that we do. We call it the Meadow Muffin Challenge. But are you able to tolerate a certain amount of carbohydrates? And what we'll see is these numbers skyrocket.
In general practice, we don't measure fasting insulin. It's not something that we look at when it comes to appreciating cardiometabolic risk. Here at HUM2N, we've introduced that. And we're seeing a lot of insulin resistance pre-HbA1c elevating, your 3-month average of blood sugar elevating.
Well, you mentioned, Dr. E, about this personalized medicine. And we're fortunate at my clinic that we're able to take people to the next step. Because again, the population testing of just doing the basic cholesterol panel isn't good enough to find that individual at risk.
Yeah.
And we need to go beyond it by looking at the inflammatory markers, the LPA,
Absolutely.
Not just fasting glucose, but sometimes the insulin. So to really find those additional risk factors when it looks like they're doing everything right, but there may still be a hidden risk. Our job is to personalize it for longevity and optimize everything that you're doing to try to find that extra little piece. So I feel by looking at this extra data, you're actually able to kind of catch some of those that might miss by using the traditional risk factors.
I want to bring it back to the context of longevity here. And you touched upon the Dean Ornish. That was your aha moment working with Dean Ornish at 18 years old. Tell us about that study and the outcomes of that study over 30 years in terms of the outcomes of a lifestyle-based approach versus an interventional approach.
So what Dean Ornish did, he came to Omaha from California, so everybody was afraid of him already. But he was a cardiologist that decided if we find people who have had heart attacks, and these are people with 2 and 3 vessel disease that were plugged, and they would remove the veins from the leg and replumb the heart. He taught them how to exercise, how to eat correctly, how to have a stress-free life, and how to build relationships. All the lifestyle things you mentioned earlier. And his group has done better. It's now 40 years later, less hospitalizations, less deaths, less medications in the group that he studied originally. It's a difficult plan for everybody to do, but it just gave us an idea that the medication isn't the answer. And his group actually has done better from it.
Isn't that amazing? That's longevity, quality of life for a longer period. I want to ask about the risk of the medicating. I saw a patient yesterday, actually today, I saw his bloods, and he's been on statins for a long time, and his HDL was on the floor, his LDL was also kind of on the floor. What are the risks of having too low a cholesterol?
So this is also interesting for me to discover in my pursuit for the greater truth on heart disease. So 2016, partly because what was interesting from Framingham and was never really mentioned was that once you hit 50, as your cholesterol lowered, your death rates increased. So myself and a number of international doctors and scientists decided to do a systematic review to look at, first of all, was there a relationship between high LDL cholesterol and heart disease in people over 60? What was that relationship? And we found, first of all, there was no relationship. And the second thing was we found an inverse relationship between LDL and all-cause mortality. In other words, statistically, the higher LDL if you're over 60, the less likely you were to die. And The likely reason for that is cholesterol has a really important role in the immune system, LDL in particular. So older people are vulnerable to dying from infections like gastrointestinal infections, pneumonia. So probably that's some protective effect of LDL. And of course, it also busted the myth that LDL is the be-all and end-all. And the other side of it, what's interesting, is that people traditionally with lower levels of cholesterol tend to have higher rates of cancer. And again, it could be an immune system effect as well. So I think there is a potential issue. Certainly when you look at one of the side effects of statins, it can cause cognitive impairment and it can actually mimic dementia. So a lot of patients have been misdiagnosed as having early dementia because they've been on statin for many, many years. You stop the statin and suddenly their mental clarity comes back because, of course, cholesterol is important in the brain, it's important for synapses and cognitive function.
We know that cholesterol is the backbone of vitamin D, and a lot of doctors don't believe in the benefits of vitamin D. And part of what we do in medicine is, in America, the range for vitamin D is 30 to 100. And if you're 31, you're deemed okay. So there's a normal range, which in America we call it the Grand Canyon of normal. You can be on one rim or the other and still be in it, but your view's different. You can have a foot on the English Channel, you have a foot in England or a foot in France and still be standing in the English Channel, but your view's different. So just because you're in a normal range doesn't mean it's optimal for you. And that's what personalized medicine is really all about, this idea of optimizing these pathways. And so, again, vitamin D, our range is 30 to 100, and when it's 31, it's not optimal. We need it 60 to 80. Doesn't want to be 130, but there's an optimal spot in these ranges. B12 is another good one. In America, it's 200 to 1200. What's the first test we do for dementia? It's a B12 level. And a lot of people, when it's in the low 200s, we get it up to 900, or we get it to the higher end of that sweet spot, I call it, and it's a game changer. I've seen the dementia with statins multiple times. And again, we're all fatheads. We need cholesterol as a building block, backbone of vitamin D, backbone of our hormones, backbone of our nervous system tissue. So everything, the body's very wise. It has a place for it. And trying to override that mechanism sometimes gets us into trouble.
Yeah. And talking about the packaging up of cholesterol and the processing of cholesterol and the relationship between our liver health, digestive tract and cholesterol. We're seeing a lot more liver toxicity in the markers that we're testing within our patients, and we're sending more patients off for liver ultrasound scans.
You think from statins, you mean?
Just generally in the population.
From sugar.
Yeah.
Yeah. Okay. Fatty liver. Of course.
Yeah, fatty liver.
Yeah.
It's 42% in America is what they're predicting the current. It was 1 in 3, now it's over 40% of fatty liver. We have a machine that's a bioimpedance analysis that tells you your overall body fat, but it's able to send a signal through the viscera and calculate your abdominal fat. There are some ultrasound technologies that are available to look at this fatty liver, and I'm shocked at how many people look like they're healthy, but they have elevated liver tests and they have.
And usually that goes with the high triglycerides as well. The fatty liver correlates quite well. You'll see that on the cholesterol profile often.
And diabetes and insulin resistant,
absolutely.
early elevated sugars. They all kind of, it's a fire, and what's fueling your fire? And that's where this personalized approach really makes sense, is you could have the same number but have 10 pathways to get there.
It's interesting, one thing that opened my eyes up to functional medicine was in 2018, I woke up one morning with a very sort of itchy rash. I'd had a lot of stress going on. Anyway, long story short, I got diagnosed with psoriasis. Spent about a year trying to, keep it under control, itchy scalp, whatever, all that kind of stuff, and using occasional steroid creams, but it would keep it at bay for maybe a few days and it'd come back again. And I met a functional medicine doctor in India. She's like the most well-known functional medicine doctor of India, called Dr. Anjali Huda in Delhi. And interestingly, she'd read my first book and recognized me in the street in a market and said, "Is this you?" And I said, "Yeah," and then we met. Anyway, so she was amazing. And she's trained in functional medicine in the US, having had a traditional degree as well. And she said, "Asim, let's check your vitamin D levels." Now, I got them checked, but they were still within the so-called normal range. But she said, "Listen, in functional medicine terms, this is low, we need to increase your vitamin D." I said, "Okay, fine." I did nothing else. Within 6 weeks of her putting me on high dose vitamin D, it completely cured my psoriasis, which I'd been struggling with for a year, completely. I didn't look back again, of course, until more recently. But yeah, that for me, then I was like, okay, that's really interesting. That made me think. There's, the personalized approach, but also some of these tests may not be actually optimal
Or looking-
values for a lot of people.
Yeah, and beyond the optimal values, looking at the whole picture, the interconnected, intricate way our human body operates. And that's been a real revelation for me going through functional medicine, where, you know, in traditional medicine, we're reducing you down to an organ and just looking at a few markers to screen that organ. Whereas in the functional approach, we're looking at, you know, markers that represent multiple systems that are connected to produce your state of health.
Yeah.
And so we are trying to connect up liver toxicity to cardiometabolic disease or to the problem that you're dealing with the most, but then also looking at blind spots that you're not aware of as a patient and that other doctors aren't looking at because they're not looking at your complete markers.
Yeah, it's a really good point. I think one of the problems with allopathic traditional medicine is that we are trained to be more like biomedical technicians, not to be healers. And that's partly also because we're looking at an individual organ rather than looking at the whole system, which I think functional medicine looks at things much more holistically.
You know, we throw these terms around and to make it easy for everyone, holistic medicine is what Dean Ornish did. He treated the whole person. Then Andrew Weil in America came up with this integrative medicine model. Treat people with medicine and nutrition and lifestyle, integrate them together. Well, now we talk about this functional root cause. Look for why you have the problem, not just treat the problem. I call it lotions and potions for psoriasis. I see so many people that have tried everything topically, it doesn't work, and we get the gut healthy, we find the vitamin D fix, we're able to find that one thing why you have it, because we could have 10 people in front of us with psoriasis, they have 10 different paths to this end problem.
Yeah.
And that's really what we're talking about when we talk about personalized medicine, precision medicine, functional medicine. We treat the whole person. Why does this person have that problem? And it could be completely different from the person you're going to see tomorrow with it. That's what makes it fun. It's also what makes it hard because you have to think out of that box. But if you get all of those root cause imbalances, deficiencies optimized, most things get better.
Yeah.
Blood sugar, arthritis, skin conditions, and heart disease.
And what else I love about the functional medicine approach is about optimal function as well. It's not just about helping you cure your particular chronic disease, etc. It's about how can you be in the best possible state, your best version of yourself, mentally, physically, socially. And that's, I think, what the functional medicine approach brings to the table as well.
Absolutely.
It gives you, you know, it maximizes your potential as a human being.
Absolutely. And
A good analogy to that is if you buy a brand new car, there's a thermometer gauge, a thermostat in your dashboard, and it's straight up when you buy the car. After 5 or 6 years, it's off to the side a little bit. Your car still starts and runs and it works, but you know it's not as efficient. So we try to get everybody's thermostat right in that sweet spot.
Yeah.
And if you do that, most things that people deal with get better. They don't always go completely away, but they get much better.
I want to circle back to the risk of statins. So statins, from my understanding, will reduce your cholesterol, but also kind of do that through the mitochondria. Should we dive into that?
Yeah, sure. I think all the mechanisms of side effects aren't necessarily fully understood, but we do have good data on the side effects and the prevalence of them. I've probably been maybe the most controversial doctor in the world in highlighting it and having backlash because of that. It depends what data you look at. So in terms of the way I describe it is, and this is what's important to patients, and you ask them the question when they come with a symptom and you think it might be a side effect, is this interfering with the quality of your life, yes or no? And the people will usually have an answer for that. That's the first thing. So then you know it's important. And the most common side effect from statins consistently in the literature and in my own experience is usually muscle pain and fatigue, which of course is not ideal. And of course that, you know, probably from some effect on mitochondrial, you know, dysfunction, causing mitochondrial dysfunction. And it's also actually even some of the guidance on statins is that if people do intense exercise, then they will notice that they're not able to perform as well. So I'm pretty convinced that there is that accepted, even amongst the drug companies, they know that it causes mitochondrial dysfunction. But of course they will argue, well, hold on, it's got such a great benefit in preventing heart disease, so it's worth it. We can get onto that. In terms of prevalence of side effects, I would say, from my experience, I think at some point, probably, and it's reflected also in real world data, 20 to 50% of patients 20 to 50% of patients will experience a side effect that interferes with the quality of their life. And it can include things like stomach upset, cognitive dysfunction, erectile dysfunction, which is not nice, muscle cramps, of course, fatigue. The good news is, you know, let's be completely honest with people here. most of these are reversible within a few weeks of stopping the statin. And often, if you're not sure, I do it on a trial and error basis and say, listen, I think it's likely the statin. Let's see how I get on. And it's amazing how many patients come back thinking, oh my God, I feel like a new person. I thought I was just getting old, or this is my life now. And they feel they've got a new lease of life, within a few weeks of stopping the statin. So then it's about an informed discussion about whether the statin's right for you. And in general terms, Mohammed, I think we've discussed this before, but it's important to repeat these numbers because people get quite shocked by them. If you're at low risk of heart disease, which is most people prescribed statins are not in the very high risk category, at best, based upon industry-sponsored studies that have never been independently evaluated, that's really important, really crucial. That's part of the controversy that's still ongoing, is that the raw data from all these studies has never been independently looked at. If we trust the data from the drug companies, which we shouldn't, but let's say we trust them, best case scenario, over a 5-year period, it gives you a 1 in 100 chance in preventing you having a non-fatal heart attack or a non-disabling stroke without a prolongation life expectancy over that 5-year period. And when you tell patients that, most of the people, those are not great odds, and they'll say, well, I don't think I want to take a statin, doc. And I'll say, great, I support your decision if that's what you want. And they will often ask, well, is there anything else I can do? And of course, then you can talk about lifestyle changes, nutrition, stress reduction, etc.
It's interesting because we see on television, we hear in the literature, it's a 50% benefit or 75% benefit. But we know that you need to look at the number needed to treat.
Yeah.
How many people do you have to treat for how long to get one person's benefit?
Yeah.
And what are going to be the number needed to harm? How many people are you going to hurt along the way to try to get to that number? And they are shocking for these raw data numbers. And the data for diabetes, in some studies, it's 8.9%, almost 9% of people who take a cholesterol drug will develop diabetes directly from that cholesterol drug. But we feel that we're preventing a heart attack, so it's okay that we develop a diabetic. And as you mentioned earlier, there's primary and secondary. And I'd love your opinion on the data there. Does it prevent you from having your first heart attack?
Yeah.
Or if you've had a heart attack, does it help prevent a second one?
Yeah, so good question. So in the secondary prevention, so people have had a heart attack or diagnosed with severe heart disease, the data tells us 1 in 39 benefit in preventing a further heart attack, and 1 in 83 will have their death delayed or save their life because of the statin.
It's really low, isn't it?
And again, and it's not that great. And the other interesting thing when I looked at the data carefully is that, again, not independently verified, but these are in patients that did not get side effects. So what they did at a lot of the early trials is they removed patients with side effects before the trial began. So you're reporting people without side effects. So when I tell patients, I say, listen, if you don't get a side effect, then this is your benefit. If I get a side effect, I made this point in my book, Statin Free Life, I would say that if you get a side effect, the likelihood is you're not getting any benefit from statin whatsoever. Even that 183 figure. And something more interesting, which I came across recently, David Diamond did a paper on this. They looked at the clinical randomized control trials in primary prevention and secondary prevention, 2 of them certainly, where they were looking at people's cholesterol profile and looking about the benefit of the statin. And the interesting thing was, in secondary prevention, you've had a heart attack. If your triglyceride to HDL ratio was normal to start with, there was no benefit at all from the statin whatsoever. What gets you a normal triglyceride to HDL ratio? Low carbohydrate diet. Or a low refined carbohydrate diet. Low sugar, etc.
Circling back to your 9% that have diabetes, I mean, this is our world, lifestyle medicine. We see the role of nutrition, lifestyle. So we're believers in this completely. 9% of people that have statins. Why is that? What's the mechanism of action there, or the theory behind it?
As Asim mentioned, is that different studies say different things. And I'm an internal medicine specialist. I like data. I like double-blind, placebo-controlled, multi-center international trials to give me a decision to decide what to do. But you have to look objectively, as you do the best job of, at how was the trial done, who did the trial, was the data released. It's very complicated in just making a decision. When you see the flash on TV, helps 1 in 3, helps 40%. You just have to be very careful of that. The little thing in your cell called the mitochondria, which takes food and helps you make energy, is directly sensitive and susceptible to those statin drugs. And it's dose dependent. And it's probably a genetic vulnerability that we don't really understand. Who's the canary in the coal mine that's going to get the most damage from it? But the statin essentially poisons the mitochondria so that it doesn't make those as efficiently. We also know that there's some interaction statin with the liver for some people. And your liver is kind of your detoxification factory. It takes all the bad things in your body, puts water on them or other chemicals on them so you can get rid of them. The statin interferes with both of those mechanisms in most people, and some to the point where they have to stop the medicine. And so we use a nutritional supplement called CoQ10. We try to support the liver. We try to do lifestyle changes, keep the body moving, low carbohydrate diet, low refined sugar diet, the good fats, not the bad fats. So there's things you can do to hedge your benefit or potential risk by doing the medications. And if you look at all medications, they all do nutrient depletions and have other things that we don't really talk about. The blood pressure pills do, the blood sugar pills do, and the statins certainly do. I was told by someone on the first clinical trial of statins that they saw the CoQ10 potential deficiency with statins and they were going to put it in the drug, but it cost a few pennies more per pill and decided not to. So it was on the radar at the very beginning of this.
Interesting.
And then I see people coming to my clinic, it seems like their doctor just has one dose they like to use. And the doses in the States, 5, 10, 40, 80. I'll see these incredibly high doses that we can use a lower dose, a little bit of lifestyle change, and if someone truly needs it, and that's going to be my next question to you, Asim, so get ready, is that you can actually get by in most of your medications with a much lower dose if you're optimizing these lifestyle changes on your way to getting rid of them. Now, a lot of times you can't just stop a medicine, and you shouldn't ever without your doctor's permission, but you can introduce lifestyle changes that help you reduce your medication and your burden from the medications.
Yeah.
And that markedly reduces the side effect profile and the danger with these drugs.
Yeah, I completely agree. And in fact, that there is not one size fits all approach to this, whether you take a statin or not. I often speak to the patient, and it's sometimes a grey area. I say, well, listen, if you feel more comfortable being on statin, but you're getting side effects, let's try in a low dose. Let's do the lifestyle as well. And then it's a dynamic process. One conversation with one patient at a particular time may then change several months later. That's important, isn't it? I always say to the patient, listen, we can come back to this, and you can think about it again, and you may want to stop the statin, and that's fine, right? So it's about treating the right patient with the right conversation, the right intervention at the right time.
Let's talk about kind of when you would prescribe, be it statin or other medication, Mark, in practice. You got so we talked about apolipoprotein B being the subfraction that you're looking out for, and lipoprotein little a as this subfraction. So you see a patient that has high LPA. What are you doing, and other kind of risk factors? What's going through your mind? How are you going to approach that patient?
Well, for me, it's a pattern recognition. And it's not an absolute number of any one marker. It's the pattern recognition. And you can have perfect lab tests and eat a bad sugar diet, not exercise, have a lot of stress, be a very angry person, and you're a higher risk than someone with the same numbers. So it's not just your numbers, it's the milieu that those numbers live in. It's the person those numbers live in. You can have great numbers, but take poor care of yourself and you're at huge risk, or have really bad numbers and do a lot of good things for yourself, and it's a different risk. So it's not one thing equals one thing. And I really feel that this approach to lifestyle medicine, prevention, integrative, functional, everything we're calling it, and really the longevity, it's not living to 150. It's hiking and biking with your grandkids when you're 80. It's capacity. We were taught get people to 50 and then watch them go to the nursing home in America. My patients want to be their best today, and we wrestle every year to keep them at that. What's that?
I've got about 4 years left.
Yeah. So it's this optimal vitality and this energy, and all that's possible. But you do good medicine first.
Yeah.
And again, the lowest dose with the most benefit, and you can use it as a leverage to get and encourage people to do the behavioral choices.
Okay, and I'm going to circle back on the mitochondria, because we love the mitochondria here at HUM2N, and it really fascinates me that one of the most commonly reported side effects of statins is proximal myopathy, and the size of your proximal muscles is directly linked to your longevity. And that's been more recently showed. And the highest concentration of mitochondria is in the proximal muscles of the leg. And so if we're taking medication that's going to be reducing the function of our mitochondria, we know we're going to be inadvertently decreasing quality of life and then length of life as well. In terms of the therapies that we use here, we're using things like hyperbaric oxygen therapy. Obviously, the core nutrients we talk about here a lot, the substrates, the NAD+, the B vitamins, the methylated forms, and the other therapies that you can get here. We're seeing a kind of, when we approach patients from that mitochondrial perspective, we're seeing a significant increase in quality of life in the short term. And we're hoping that will continue for the long run as well, because these are ultimately safe interventions, micronutrients and oxygen and pressured environment. I just want to touch on homocysteine. We haven't talked about that. And that's a kind of a marker that represents how well methylation is performing within our cells. We've been looking at that in functional medicine for some time. Mark, how much fuel to the fire does homocysteine add to the blood vessels inflammation?
I feel, again, everything is determined by the setting in which it is there. So what the homocysteine, the way I explain it to people, it's just a bad protein in your blood, and it kind of chews away at the blood vessels and makes them more at risk. It's bad for the heart, it's bad for the brain, maybe some link to cancer. It's just a bad protein in your blood. And some people have this methylation defect. It's a genetic inefficiency. Doesn't mean you're broken, doesn't mean that you aren't going to be able to function. It just means that you don't take the nutrient B12 and folic acid and convert it into something your body can use. 40% of women don't do that. And homocysteine is directly related to the functionality of you taking that folic acid and the B12 and using it. So homocysteine is part of the story. And again, the easy way I think about it is as this toxic protein. The studies do show it's a synergistic risk to the bad cholesterol particles and the inflammation. For me, it's a pattern recognition. Yeah. It's not one thing.
Of course.
But, is it a non-specific inflammatory marker as well?
It is.
Yes.
You'll find when the CRP, which is our inflammatory marker, is elevated, the homocysteine a lot of times tags with it.
Right.
And you can give all the B vitamins that are methylated that you want. If there's a hidden source of inflammation, which is usually the gut, it's a food sensitivity or dysbiosis. So that
can raise homocysteine as well, isn't it?
It can keep the whole, it makes the whole pattern just not want to cool down.
Yeah.
But I think it's a 1 + 1 + 1 = 10.
Yes.
It's a negative synergy when you start adding all these risk factors together.
You mentioned women. You've written a book on women's heart health. Why did you dedicate so much time to specifically talk about heart health in the female population?
Well, most studies are done on men. And we kind of forgot that women are a little different. Their anatomy is different, their endothelium is different, their hormonal milieu in which this exists is different at different times in their life. They just are a little bit more special to me in that we need to think about them as even more unique. The women in our world need even a more personalized approach than we do because they're different at different times. And they have different vulnerabilities. The lipoprotein A tends to be more of a risk factor for women. It's more of an inherited risk factor in women. And during my residency, I saw several women that were admitted with abdominal pain and thought that they needed their gallbladder taken out, and they actually were having a heart attack. And so they present differently, they have their symptoms differently, their anatomy is different. And I think what I really saw is that it's a challenge to individualize and personalize to try to help them have the least risk and best outcome. The beautiful thing is that, Asim, with what you're doing in this preventative cardiology type realm, you're helping women's hormones be better. They're sleeping better. They're not as inflamed. They're not as fatigued. They're emotionally happier. It's amazing how when you're addressing one thing in functional medicine to be better, you're actually having this downstream effect. Because you're not treating a number, you're treating the whole person. And everything seems to get a little bit better. It's a fun way to practice.
I won't go into kind of female hormones. I think that's going to be another podcast we'll have to do together with you, Mark. And I think we've covered off cholesterol, statins, modifying your personal risk in good depth. And please feel free to ask us any questions, engage with us in our community.
Dr. Nat, may I ask a question?
Yeah.
Asim, who do you give a statin to? Who do you feel benefits of all these populations?
So with every patient, I will give them the numbers, I'll explain the situation, uncertainties in the evidence, alternatives, and then help them make a decision. And most of the time the patient will say, I prefer not to take a statin, or I'll go with it. Or sometimes say, well, doctor, what do you think? But in general, that's my approach, Mark, rather than, that's kind of the evolution of what we call, that's really the initial principles of evidence-based medicine from the triad from David Sackett in the late 90s, was that you want to improve patient outcomes by using your clinical expertise, best available evidence, and last but not least, he said most importantly, taking into consideration individual patient preferences and values. So I will prescribe or ask them to carry on if that's what they want to do. But I usually let them make the decision, to be honest, as long as I feel I've given them all the information that they deserve.
Thank you.
We've been talking away, and it's been such a pleasure, and we can talk for hours on this topic, and maybe even days. What I want us to kind of close on is some key takeaways from your experience that all our viewers can start thinking about, that they can do themselves, for themselves or for their loved ones, with their loved ones. And you mentioned, we've all talked about kind of lifestyle interventions. Let's touch on the evidence base around, you mentioned the Dionish study with regards to lifestyle intervention, the long-term follow-up on there. What is the best nutrition strategy? There's no one-size-fits-all, for sure, but generally speaking, let's start with nutrition.
Yeah. So I think the low-hanging fruit, a lot of people in this space, such as ourselves, and maybe some of our patients as well, are quite advanced in terms of their understanding around nutrition. But actually for most of the population, most Americans, most people in the UK, the low-hanging fruit, the first most important thing they can do is, and they don't necessarily need to do this forever, is break their addiction to ultra-processed food. That is the major issue right now, is processed foods, and which generally are a combination of, high in sugar, unhealthy oils, refined carbs, full of additives and preservatives, designed to be hyperpalatable and probably addictive as well. There's a lot of emerging science on that. And of course that makes sense from the food industry's point of view, because that's what they want to sell you, that food. For me, the first and most important thing is to eliminate that. And I'll tell patients, listen, this isn't forever. It doesn't mean that you can't enjoy a sugary treat, at some point, but break the addiction, go cold turkey, 3 to 6 weeks. Your palate will change, you'll start to feel better, and you'll see differences, and that then motivates them to carry on. And of course, from a heart disease perspective, and there are different approaches, and I'm very open, but I think my default approach is a low refined carbohydrate Mediterranean diet. When you look at the foods that, because heart disease, insulin resistance and chronic inflammation are kind of two sides of the same coin, two evils, if you like, of heart disease. So it's combating the insulin resistance by removing refined carbs, and making sure they're having anti-inflammatory foods. And the best evidence comes from foods like extra virgin olive oil, nuts and seeds, whole fruit vegetables, and oily fish. So these are the components I usually add in from a dietary approach, and it usually has a very, in most patients, if they adhere to it, they will notice an effect quite quickly from a nutrition point of view.
So it really is that easy?
Theoretically, yes, but the difficulty for people, any kind of behavioral change needs an effort at the beginning, and that the key is really motivating and explaining to those patients that because a lot of people come in with a mindset thinking it's just about weight loss, or whatever I do is going to take a long time to see an effect. And what I say to them, listen, you're going to see an effect in 21 days. And they're like, what? And some people, some of my patients have even sent their type 2 diabetes into remission in 21 days, right? So so that people can do. You give them that. Okay, listen.
That belief.
Think you can do this for. Yeah. Just do it for me for 3 weeks, 4 weeks.
Yeah.
Can you do it? Yeah. You know what? I think I can, doc.
Yeah.
So that's how you start. That's my initial approach.
So if I may, a couple other ideas of helping people out there get started. Make it 21 days.
Yeah.
Do you give them handouts, or how else do you help educate them to motivate them to?
Yeah, I mean, handouts or stuff online, or my books or whatever else, or I'll explain it to them, or just be very specific. Eliminate all the starch and sugar, stick to these foods. And if they need further help or input, then of course I have we have nutritionists here and other nutritionists that we can use that they can get extra help with. One of the things linked to it though, Mark, I think a lot of what drives some of this behavior, and that's, again, it's all a synergy of risk, a web of causation of risk, if you like, is chronic psychological stress in the way that we live. So often I will back up the dietary approach with some sort of stress reduction intervention. I work with a really good cardiac specialist nurse who's very good at breath work. And I gauge the level of stress with them as well. And if they're not particularly high stress, then fine, they don't necessarily, but a lot of them are. And therefore that helps them. If they're simultaneously studying breath work and meditation, it'll be easy for them to break their addiction.
Stress it was on my list.
Yeah.
So stress kills. and it seems to precede a lot of cardiac events.
Yeah.
Should we just touch upon what happens inside us when we're under high stress? Our sympathetic nervous system, our adrenal glands, our hormonal response. Mark, how do you investigate that how do you investigate from a functional medicine perspective someone's underlying biological state or effect of chronic stress on them?
One of the best markers is your heart rate variability. And it's a measurement of basically your sympathetic tone or your fight or flight response. But usually you can get it from the story. What's going on in your life? One of my favorite authors is Michael Pollan. He's a nutrition author. If you go to the bookstore and look up one of his books, he has a lot of the same ideas you do. And we talk about the Mediterranean diet. Well, it's a little different in France than in Spain and in Greece and in the other parts of the Mediterranean. And if you eat a Mediterranean diet in your car by yourself while you're angry at the person next to you, there's a complete different chemical effect than when you're sitting around a table with people that you love or your dog. And it's not just the food, it's the environment in which you do it.
100%.
And the breathing teaching is, we teach everybody a 5-second in, 5-second out, put your hand on your belly before they eat. And we try to encourage them to take a walk after they eat. It's these easy things. For 21 days, that's all I need is 3 weeks for you to do it. Do a little breath work before you eat, take a walk after you eat. These little things can have huge benefits. And as you see too, as you get people to do one thing, they're more likely to start feeling better to do another and another. And then the whole wheel is spinning. And it's amazing when they come back to you how much has really changed for them without taking a medication.
What's the right exercise program to improve your blood vessel health and keep the vessels nice and open and healthy, elastic? What do you guys think?
What do you say in your book? How do you lay it out?
Yeah, so my co-author of my book and co-producer of the first film I did, a documentary called Big Fat Fix, Donald O'Neill, came up with this great line: exercise is overrated, movement is underrated. If you look at the blue zones, I'm sure you've studied this, Mark, as well, you look at the people that had these high levels these communities with high longevity.
Live longest.
These people weren't in the gym or panning the gym, they were just outside, they were just moving constantly. From a heart disease perspective, I don't overcomplicate it. I think moderate exercise regularly, whether it's 30 minutes 5 times a week, is pretty good. I do have concern, and I've seen a few patients, and this is a minority, but it's still important. Overtraining, especially if you're stressed and poor sleep, is actually bad for the heart. And about 11% of elite athletes over 50 will have coronary calcium scores above 1,000. And I've seen some of these patients come to me, and everything is great, and you look at the calcium score, and they've got significant, potentially significant coronary artery disease, and you go through their history, and they have been pounding it. They've been running 10 miles a day or something like that. It's like, okay, well, you need to tone that down. So I just keep it simple for the exercise stuff. And certainly when it comes to even people who are specifically overweight or metabolic syndrome, most of the impact is going to come from diet. In fact, there's not been an intervention, any study that I'm aware of, where you reverse metabolic syndrome just from exercise. You keep it simple. And in fact, actually, if you over-exercise and you lose weight, etc., that is also not good for the stress hormones, good for your joints. So yeah, brisk walk, 30-minute brisk walk every day. But again, do what you enjoy. That's what you have to ask them. What whether it's cycling, swimming, walking, etc. Do something you enjoy. Don't overdo it, but make it regular. Okay. That's all I say.
It's good advice. Make it easy.
Yeah.
Then if things are not just easy but successful, and when you get one little success, you're willing to maybe take another risk and do another success, and they start to build on each other, and then your pathways start to shift.
Yeah. Even things like Pilates, I do Pilates once a week with a person that comes to my place, and I find it meditative, actually.
Absolutely, yeah.
I find it very meditative.
I love what you said about movement, and the easy way to do that is when you go to the store, take a couple laps around the long part of the inside of the store. When you park further away, take the stairs instead of the elevator. Do the little things in your day that just give you a little bit more movement. It doesn't have to be a 60-minute marathon run.
Any other lifestyle factors that our audience can consider? So we've talked about nutrition, movement, stress modification, and how to manage stress. We talked about community, the way you eat, considering kind of purpose, values in there comes into that, the social element of wellness.
I mean, on that community stuff, I think, quality of relationships. I mean, a lot of what drives poor health actually is chronic stress related to work or relationship stress. It's easier said than done. It may be, you may need a complete revamp of your social circle, But actually if you look at all of the studies on longevity and even mental health, the single biggest determinant of that is meaningful relationships. So really have a think about that, you know. People who live in isolation, you know, have risk of heart disease equivalent to being a heavy smoker.
Yes.
So it's a really big one. You know, and there's a cultural issue there as well. I think we're spending a lot more time looking at screens, not interacting with each other. You know, I see people in restaurants with their girlfriends or wives, no conversation going on, they're just looking at their screens, you know. This is not good.
What's the future?
Staying off social media actually is probably a very good, except maybe for today. It's probably good advice, another lifestyle advice, minimizing. You know.
So we've got some questions from the audience. If someone had calcified plaque in their heart, can you discuss how one would go about reversing that?
So similar lifestyle approach, looking at the data on reversal of heart disease, there isn't a lot of data out there, but the one most interesting study for me, which I think supports early studies by Dean Ornish, is done by a cardiologist in India called Satish Gupta. And he looked at, and this is the early 2000s, before people were taking statins, people who had at least moderate to severe heart disease, so 50 to 70% blockages, couldn't get a bypass or a stent or whatever, or didn't want it, put them on a healthy lifestyle program, which in India, they were devout Hindus, so it was a high fiber vegetarian diet. It was two 30-minute brisk walks a day. And then it was something called Raj Yoga meditation, 40 minutes of, it was really a spiritual transformation, but it was a form of breath work. And then he followed them up, and the people who had adhered to the lifestyle plan had an average reduction in the stenosis, the narrowing, of 20%. He then did a deep dive into the data. What was it? Was it the diet? Was it the exercise? The only independent intervention for reversal of heart disease was 40 minutes of Raj Yoga meditation a day. So I think it's a synergy, but I think it may well be more than anything else, could be the stress reduction. The question is around calcified plaques. Actually, the calcified plaques are the less likely to cause heart attack. Your soft plaques are the bigger problem. I don't know about whether you can reverse calcified plaques, but certainly the soft plaque reversal you can. I had a patient only recently, just within a year of changing his diet, going on a kind of low refined carb Mediterranean diet, had a 60% narrowing in his circumflex vessel disappear in 1 year. He hadn't even sorted his stress out at this point, just from dietary changes alone. But I would say do all three together.
Well, that's such a great way to look at it. There's kind of a trifecta we use in our clinic, is we do the advanced testing for the additional blood markers that we talked about, and it's myeloperoxidase, plaque-2, ADMA, SDMA, oxidized LDL, insulin, the A1C for blood sugar, CRP for inflammation, before we even look at the cholesterol, 4-part cholesterol.
Yeah.
And we then do a calcium score. And based on the data, if your calcium score as a man over 50 is 0, your need and benefit from a statin in the next 5 years is less than 3%. So it helps us to try to guide people. And if we see someone with a heavy plaque burden, we do a stress ultrasound called stress echo. So that's kind of the trifecta I've used in the last 20 years to help risk stratify people. The advanced blood testing, the calcium score, if it's 0, we stop. If it's a concerning looking pattern, then we need to go into a functional stress test to look at what their risk is immediately.
Yeah.
And I feel like that's a great way to screen for those people that are the people, the canary in the coal mine kind of time bombs that you worry about.
Question from the audience was about supplementation. What are we missing in the modern diet? Even if we're getting we try and get the best quality food we can, but we understand that sometimes the food is micronutrient poor based on the soil that it's grown in. Mark, if you were to give some general advice of the supplements to consider, how to navigate supplementation, and what are we talked about healthy fats, we talked about anti-inflammatory bioflavonoids, etc., in the conversation that are coming through the Mediterranean diet. In terms of supplementation, what would you consider?
Well, the first thing I would do is go to your medicine cabinet, look at every supplement you have, turn it over and look at the other ingredients, because there's a dark side of supplements that most supplements are junk. They have excipients, artificial flavorings, artificial colors, most of which are banned here, but they're available in the US. I'm shocked at how low quality the supplements are that some people take. So in general, I like people to bring all their supplements in for me to see them, or they'll hold them up so I can see what the other ingredients are, and we teach them about it. I like food as medicine, kitchen's your pharmacy, lifestyle is your physician, and ideally not need any supplements. The problem is our modern world, the foods are depleted, we have chronic stress, there's toxicity all around us. To get that vitamin D level to 80, like you mentioned, you may not be able to do it just with the colors and with the oils and nutrition. And So I believe in test, don't guess. So we test for those levels and then optimize them. Many people, we call it the core four. The data for omega-3 is pretty clear if you get a good fish oil and not a rancid bad fish oil. Most people benefit from vitamin D, but you can't take too much. There's the toxicity. I never really see it, but there's some people online that are recommending really high crazy doses of vitamin D. And again, I'm a test, don't guess. If we supplement, usually 2,000 safe, 5,000 for some people, but we'll repeat it to be sure that we're safe. So an omega-3, a vitamin D, and then a general complete multi just to kind of cover all your bases, but it has to have that methyl B12 and methylfolate in it. So if you are a poor methylator, you can do the genetic test, just cover your bases. But I like the colors of the rainbow, as you mentioned, clean fats. If you spend any money on organic food, what should you spend it on? The berries. I like fruits that end in the name berry, but they're the pesticide catchers, are the open strawberries, raspberries, blueberries. They're the ones that are most vulnerable to organic. In America, we have a lot of factory farmed meats and proteins, and those are very bad in America. So the proteins and the fruits, to me, are where you really want to focus on the organic.
So you're saying berries-wise, if they're organic, you're generally pretty safe with blueberries and raspberries and stuff like that?
Well, it's interesting because organic doesn't always mean clean. Because there could be a factory right next to the field that's an organic field. And in America, we have cage-free eggs, which you could have a huge 2,000 bird warehouse with a 6-foot square open, and they could call them cage-free. So you're looking for free range. My neighbor actually has chickens and raises their own eggs and feeds them a high-quality omega-3 grain. And those eggs are bright orange when we put them in the pan to cook them. They're not pale yellow like we get from our stores. So food is not just food.
Yeah.
But no, the berries are where your pesticides you really worry about the most.
The last question I wanted to ask you is, what is the future for cardiometabolic health and getting on top of personalizing risk? Say in 5-10 years, what would you like to see be different in the future?
99% of doctors, if you ask them what metabolic health is, they wouldn't know. They wouldn't give you an answer. They wouldn't know. So I think the primary focus, the default should be, and this is again a bit of a plug for my new documentary, is first do no farm, across the board.
I love it.
Right? That should be the primary focus. We need to just make sure when it comes to heart disease, everybody should understand what metabolic health, every GP, every doctor, and they should be armed with the tools to be able to prescribe and support patients with lifestyle changes.
That's such a good point. We talk about big farm and big pharma, and they kind of work together to help make you sick. And unfortunately, that is the reality in our world. And I think there's two things I ask. One is you walk the walk and you talk the talk. The doctors have to be the role models for their patients.
Yeah.
They need to advocate like you do for clean food, for healthy lifestyle choices. If the doctor isn't aware of it, so we need to teach the doctors how to.
Yeah.
And as you have here, Dr. Enayat, you have nutritionists working with side by side, and you mentioned that as well. It's other practitioners working together as a team. We talk about it as a care team.
Yeah.
But we have to teach the physician, but also provide some tools and support for the patients. It's not that hard. And you had a great pearl of do the little stuff first. Have one success to build another success, and you'll see that steamroll. And I think a healthier future is possible. It's easy to be pessimistic, but I'm an eternal optimist.
Yeah.
And I think it starts with our kids. And what we're seeing in America is a lot of these young kids are becoming foodies. Some of them over-focused on food, but they get the toxicity, the clean foods, the dirty dozen, the clean 13. They talk about these different foods. So it's exciting to me to see young people actually become passionate about food and about health.
Well, listen, thank you both for your time, your love, your attention, both today, but your continued drive and passion to make the world a healthier and happier place. So from us, thank you very much.
Thank you.
Good talking with you.
Thank you, mate.
Let's do it.
Awesome.